Hello and welcome. My name is Hussein Hishmat. I'm an interventional cardiologist, and this is a new episode in the CHIP series, Complex High-Risk Interventional Procedures. In this episode, we'll be talking about non-crossable lesions and the role of specialty CTO balloons. We all know that PCI now is completely different than the PCI that we used to do 20 years ago. Our patients are different. They are frail, they are elderly with lots of comorbidities. The coronaries we handle are also different. We have lots of plaque burden, calcification, diffusely diseased, small vessel, tortuous vessels, previous stents, and also the myocardium can suffer because of systolic dysfunction, mitral insufficiency, aortic stenosis, etc. So what tools do we currently have to be able to overcome the coronary challenges? We have better guides and, more importantly, guide catheter extension. Our wires are better. We have low profile microcatheters, and balloons are in the center of this armamentarium for complex PCI. Of course, imaging gives us so much information. Our stents are better, thinner struts with lower rates of restenosis, and of course we have debulking. But we need to focus more on balloons because they are more handy and they are essential in any procedure. So what do we need from our balloons? Basically, we need three things. We need our balloons to be able to cross the lesion effectively. We need them to be able to dilate the lesion and expand the stent. And we need to do this without extensive dissection or perforation. But in many situations, we currently face now non-crossable lesions. And what do we mean by that? Either the wire crosses and the microcatheter fails to cross, or the wire crosses but the imaging probe doesn't cross, or our normal balloon 2.0 1.5 balloon fails to cross, or the stent fails to cross. In these situations, we need to have tricks in our sleeve, and I'll go with increasing escalation. Support wires are important, then specialty balloons, our topic today, is extremely important. Guide catheter extensions are helpful, and of course when it is a calcified lesion, then you need debulking by either rotablation or orbital atherectomy. So what specialty balloons do we currently have for crossing CTOs? We have several balloons, and it's very difficult to have all these balloons in your cath lab. So we have the NIC Nano Hydro, we have the Laxa, we have the Sapphire Pro, Ikazuki Zero, Tazuna, across the Blimp device, Sprinter Legend, and Emerge, and they all do some good job. But as I said, it's difficult to have all of them on your shelf. So it's good to think and focus on one or two only of these devices and be familiar with them. And today I'll be talking more about the NIC Nano Hydro, and I'll be providing some real case examples from our practice. So the NIC Nano Hydro has one of the lowest crossing profiles with a crossing profile of 0.019 inch, which is slightly bigger than the wire you cross. Definitely better than any microcatheter. The balloon has a proximal single marker, and this facilitates entry of the balloon. The balloon is more or less a non-compliant balloon, although it's a miniature balloon, 0.05, and if you're familiar with the OPN balloon, we can call this the micro OPN balloon, because it can go up to more than 20 atmospheres, 23 atmospheres. And when we go up to that high pressure, the maximum diameter that the balloon will reach will be 1 millimeter. The balloon is available in two sizes, 0.85 millimeter and 1 millimeter, and we usually keep at our shelf only the 0.85 to use when we are unable to cross the lesion. So when we do resort to this balloon, as I said, in a CTO, when the wire crossed, the specialty wire crossed, you're trying to cross with a microcatheter to exchange for a workhorse wire, but the microcatheter doesn't cross. Here, your only option is a CTO balloon. Or when you cross the lesion and you exchange for a workhorse wire, but the normal balloons 1.5 and 2 millimeter are unable to cross. In calcified lesion, before you do a rotablation, especially if the vessel is tortuous, if the vessel is diffusely diseased, or angulated, or you need to do a long segment of ablation and avoiding the wire bias, it's good to have some lumen because this may minimize the risk of root ablation complications. In bifurcations, when you place the stent in the main vessel and you need to cross into a diseased side branch through the cells of the stent, it can be challenging in many situations. And lastly, in small vessel, diffusely diseased tortuous vessels, where the crossing ability of other balloons does not help you to deliver across the lesion, and here the Nick Nano is the solution. So I'll be providing two quick examples where this balloon proved extremely helpful. The first situation is for a non-crossable lesion. This is a 41-year-old gentleman with diabetes, hypertension, dyslipidemia. He presented with an acute inferior ST elevation MI with an RV infarction. And this is his left system, and you can appreciate how terrible the disease is. You cannot find any single coronary branch that is not extensively and diffusely diseased. You see it in the left anterior descending, in the branches, in the circumflex, in the lateral and the posterolateral branches, and you can see also that the right coronary is occluded. This is the angiogram of the right coronary artery. We see an early bifurcating RCA, it's a dual RCA with a large RV branch that shares also the marginal supply of the heart. And of course we knew that this patient is not the ideal candidate for angioplasty, but he was also not an ideal candidate for CABG. And we agreed with the surgeon that we need to fix the culprit vessel of the STEMI and then decide what's the next step with it. Would it be medical treatment or surgical revascularization? You can appreciate here that the right coronary is small caliber, some tortuosity and angulation, diffuse disease. You can also see that there's a calcified lesion very proximal shortly after the ostium. We crossed rather easily into the marginal branch, the RV branch, with a workhorse wire, and we tried to cross into the main RCA with a workhorse wire, but we couldn't. Eventually we crossed with a run-through wire, and then we tried to cross with our balloon. Here we had a Laxa balloon, but as you can see, the balloon is unable to cross the lesion and it keeps pushing the guiding catheter out. At this time we didn't have the option of placing a guide catheter extension because you can see there is severe calcification and significant disease very proximal. So placing a guide catheter extension here was not an option. The only option here was to find a low profile balloon that's able to cross. And then we got the Nick Nano Hydro, the 0.85, and you can see it here going through the guiding and crossing the lesion very smoothly. This balloon is of very small diameter, 1 millimeter, so when you inflate it, you may barely appreciate a radio-opaque shadow in the coronary. After we crossed and inflated, we were able to inflate bigger balloons. Here there is a 1.5 millimeter balloon. And then we used the same balloon, Nick Nano Hydro, to cross into the big RV branch and dilate. And this is the final result after we ballooned the right coronary with non-compliant balloons and cutting balloons in the proximal segment. And we agreed that we will not be placing any stents to keep a window for the patient to go for CABG in case he complicates or the surgeon decides an early procedure. The result may seem like mediocre, but if you compare this result to the baseline result, you see how significantly the vessel improved, the flow improved, and this would have never been possible unless we had a very low profile balloon like the Nick Nano Hydro crossing across the stenosis. The second case is even a more challenging case where crossing through the stent was a life-saving procedure. And so the patient here was a 65-year-old lady with diabetes, hypertension, dyslipidemia, chronic kidney disease. She presented with acute inferior MI and she was in shock. We did PCI to the culprit RCA and the vessel was densely calcified, so it was difficult to deliver the stent except with the help of a guide liner. The patient recovered from shock, and then she was scheduled for the non-culprit PCI during the hospitalization. You can see again the nature of her vessels. The LED is calcified, the diagonal is also has some calcification. The LED is of relatively small caliber and is diffusely diseased. We knew that this is a case for debulking from the start, so we went ahead with a 1.5 millimeter burr and we ablated the lesion in the LED. We didn't think that we would need to do calcium modification for the lesion in the diagonal. We thought that the balloon angioplasty would be sufficient on its own. However, after we did the rotablation and we dilated the diagonal, we found that the patient starting to go into hypotension. The result of ablation in the LED was fine. There was no significant distal embolization, but you can see here that the flow in the diagonal is starting to be compromised and there's probably some dissection in the diagonal. We were not sure actually what was causing her hemodynamic collapse. You see here we inserted an intra-aortic balloon. The stent in the LED was fine, but we had complete shut-off of flow in the diagonal branch. And it seems that the lady was strongly dependent on this flow in the diagonal to preserve her contractility. Once we lost the diagonal, the systolic blood pressure went down to 60 and we inserted the intra-aortic balloon. So it was essential that we recross into this diagonal branch and force it open. The only wire that we were able to deliver was a CTO wire, the Fielder XT, and you can see here it's going inside the diagonal. But the problem that we faced, that we were unable to deliver even a 1.5 millimeter balloon. You see here how the guiding is falling out of the coronary, and the wire is about to be also coming out of the diagonal branch. This is just with a 1.5 millimeter balloon. And crossing into this diagonal was a matter of life and death. So we brought here the Nic Nano Hydro 0.85, and as I told you, you can barely see it with a radio opaque shadow, especially when the wire you're using is a radio opaque wire like the Fielder XT. But the Nic Nano was able to cross into this calcified diagonal through the stents, and it was able to give us a channel. After we used this channel, we were able to deliver bigger balloons, and once we did that and we re-established flow in the diagonal branch, the patient was revived and her blood pressure started to build. We realized that this diagonal cannot be treated by balloons alone and it had to be stented, so we ended with another stent in the proximal LED and another stent and a stent in the diagonal. And you can see here the kissing, final kissing for the LED and diagonal, and this is the final result. We regained the diagonal and the LED flow was great, the diagonal flow was great, and regaining the diagonal, the life-saving diagonal, again could not have been possible without having a low-profile balloon like the Nic Nano Hydro. So to conclude, the tools that we need for complex PCI include the guide catheter extensions, the wires, the microcatheters, the balloons, the imaging, the stents, and the debulking. But the balloons remain in the center of your tools for complex PCI, and you need to have on your shelf a good CTO balloon that's able to cross even in difficult situations, in uncrossable lesions, and through the struts of a stent into the side branch, and this might be the life-saving. Thank you so much. If you like the content, please hit like and subscribe so that you get the updates, and see you in the next episode.